Now we're going to start talking about the anti-rheumatic medications and immune modulators. These include the conventional disease-modifying antiarrhythmic drugs, antimalarials, sulfamides, antinoplastics, immune modulators such as cytokine blockers, TNF-alpha inhibitor, cytokine blockers, IL-1 receptors, antagonists, T-cell modulators, and corticosteroids. And what are these used for? Rheumatoid arthritis. These drugs are generally initiated by a rheumatologist. Patients on these medications are seen in the primary care setting, and you need to just be familiar with these drugs. All patients with suspected rheumatoid arthritis excuse me, should be referred to a specialist for evaluation and initiation of medication. As a primary care provider, you should work with the specialist in monitoring the course of the disease, identifying possible adverse reactions. Methotrexate is very commonly used. It's a disease-modifying anti-rheumatic drug. It's also well tolerated and produces beneficial effects within 2 to 6 weeks. There's new drugs on the market, JAK inhibitors, used to treat patients with moderate to severe rheumatoid arthritis, particularly adolescents. Again, drugs are being developed as we speak, and it's really important for you to keep up with this constantly. Again, drug treatment for rheumatoid arthritis continues to evolve. The conventional DMARDs, or disease-modifying antiarrhythmic drugs, methotrexate, hydroxychloroquine, and sulfasalazine remain common in use. Previously, gold salts, penicillamine, and azathioprine were used, but these are now indicated only if all other therapies fail because of the toxicity of these drugs. The newer immune modulators are becoming increasingly important in the treatment of rheumatoid arthritis, and again, the field continues to change rapidly as these agents develop and new mechanisms of action are also developed. Many agents are currently being investigated in clinical trials. Mechanism of action. The conventional DMARDs have anti-inflammatory effects that may slow disease progression and preserve joint function. The exact mechanism of how they work in rheumatoid arthritis is unclear. For hydroxychloroquine, it's been suggested that this hydroxychloroquine sulfate acts by mimicking the action of its parent compound, chloroquine. The antimalarials possess anti-inflammatory properties, which possibly are seen as inhibiting the conversion of arachidonic acid to prostaglandin F2. In vitro, these agents interfere with the chemotaxis of polymorphonuclear leukocytes, macrophages, and eosinophils. The sulfamides action remains unknown. It has an anti-inflammatory action and reaches high concentrations in serous fluids in the connective tissue. So specifically, the methotrexate is used because it possesses both anti-inflammatory as well as immunosuppressive properties. Evidence of clinical efficacy has been shown in numerous studies. This agent acts by inhibiting dihydrofolate reductase and the 5-amino indazole 4-carboxamide ribonucleic transfer amylase, resulting in impaired DNA synthesis. Furthermore, it exhibits inhibitory effects on cytokines, especially the interleukin-1, and may alter arachidonic acid metabolism. Methotrexate also exerts an anti-proliferative effect on synovial cells. The immunomodulators are agents that regulate the extent and duration of immune response, known as immunomodulators. Cytokines such as tissue necrosis factor, TNF, and interleukin are some of the many substances the body releases during the inflammatory response. Through genetic research, these agents have become clones so that they can be produced outside of the body and given to patients who are immunodeficient. Many are indicated for the treatment of rheumatoid arthritis. Some are indicated for multiple sclerosis. Drugs that target cytokines and T cells include the TNF, or tumor necrosis factor, interleukin-1, and T cells. Cytokines are cellular messengers that initiate and perpetuate the inflammatory response by stimulating the production of cartilage-degrading enzymes and allowing pannus and inflammatory exudate to attach to cartilage and bone. The two cytokines, again, targeted by the new immune modulators are the TNF and the interleukin-1. The cytokine blockers, TNF inhibitors, bind to TNF and inhibit its interaction with cell surface receptors. The cytokine blocker interleukin-1 blocks to interleukin-1 by competitively inhibiting binding to the receptor. Interleukin-1 mediates inflammatory responses and causes cartilage degeneration. Again, these are a lot of the drugs that are going to be initiated by the rheumatologist. However, you should just be familiar with their mechanisms of action. For the corticosteroids, these inhibit the production of interleukins. The inhibition decreases the immune response through diminished activity of T cells. Corticosteroids also affect both type and number of leukocytes and monocytes in serum. The anti-inflammatory effects of corticosteroids overlap with the immunosuppressive actions. They affect carbohydrate, protein, and lipid metabolism and increase hepatic gluconeogenesis. The JAK inhibitors, this is a new drug class and is entering the market. These drugs interfere with enzymes that contribute to tissue inflammation. For treatment principles, the DMARD, methotrexate, is widely used as a first-line treatment in individuals with rheumatoid arthritis because consensus about its effectiveness in practice. Sulfasalazine and combined treatment with methotrexate and sulfasalazine are as effective as methotrexate in improving pain, joint swelling, and function in people with early rheumatoid arthritis who have not previously received these DMARDs. Antimalarials may improve symptoms and function in DMARD-naive people and are reasonably well tolerated, but radiologic evidence of erosion is more marked with antimalarials than with sulfasalazine. A variety of DMARDs are available for second-line treatment of rheumatoid arthritis, and no clear evidence suggests either are superior. Methotrexate, sulfasalazine, penicillamine, and leuthonamide cause similar improvements in symptoms and function when given to individuals as a second-line DMARD treatment, although methotrexate causes fewer adverse effects. For the cardinal points of treatment, for patients with active rheumatoid arthritis, non-biological DMARDs are the first choice of pharmacotherapy. For an individual who is receiving any of the 5 known DMARDs shown by radiograph to slow damage from disease progression. These include the sulfasalazine, methotrexate, flufenamide, etc. Acetaminophen or Tylenol may be used with these medications for mild pain. However, because rheumatoid arthritis is an inflammatory disease, many more patients will benefit from therapy with an anti-inflammatory medication such as a nonsteroidal or a corticosteroid. The COX-2 selective nonsteroidals can be used as with these medications for the person with a moderate to severe pain or with or without inflammation, unless clear risk factors for exacerbation of renal disease, adverse effects present, or the medications are not tolerated because of the GI complications. Although research results do not always agree, it appears that the patients with arthritis treated with the COX-2 inhibitors often become prone to stomach ulcers and internal bleeding if they do not take gastroprotective agents to counter irritation of the stomach and esophagus. If the anti-inflammatory medication and the DMARD provide inadequate pain relief, then acetaminophen should be added. If GI risk factors are present, then prophylactic protein pump inhibitors should be given along with the non-selective non-steroidal anti-inflammatory. Patients at risk for cardiovascular events should be given a regular low dose of aspirin, whether treated with a non-selective or COX-2 selective non-steroidal. Low-dose oral glucocorticosteroids, less than 50 milligrams per day of prednisone or equivalent as a single dose, should be considered for short-term use in patients with rheumatoid arthritis. The medication has been shown to decrease progression of erosion in the first 2 years. When oral glucocorticosteroids are used, prophylaxis with biphosphonate should be considered along with calcium supplementation and daily supplemental vitamin D to lower the risks of glucocorticoid-induced osteoporosis. Intra-articular glucosteroids should be used in patients with intense flares of osteoarthritis or rheumatoid arthritis and sometimes joint pain with the osteoarthritis, as evidenced by high degrees of inflammation and infusion in the joints. They can be used at any time during the course of the illness. Opioids should be used for patients with osteoarthritis or rheumatoid arthritis when other medications and non-pharmacological interventions produce inadequate pain relief and the patient's quality of life is affected by pain. Morphine, oxycodone, hydrocodone, or other mu agonist opioids given as a single agent or combined with a nonsteroidal or with acetaminophen should be used for moderate to severe osteoarthritis or rheumatoid arthritis pain. It has not responded to other treatments. The use of codeine and propraxiphen should be avoided because of its side effects and limited analgesic effectiveness. The DMARDs are immunomodulators, generally are prescribed by the rheumatologist. Other healthcare providers are often involved in monitoring the response to the medications and adverse reactions. The JAK inhibitors are used particularly in adolescents who cannot tolerate methotrexate or for whom it's ineffective. For non-pharmacological treatment of rheumatoid arthritis, include patient education, addressing the emotional impact of rheumatoid arthritis, physical and occupational therapy, systemic rest, articular rest, exercise, use of heat and cold applications, assistive devices, splints, and weight loss if overweight. There are several herbal complementary and alternative products that are used by patients to relieve symptoms, so you need to ask the patient if they're using any of these and be aware of any possible drug interactions. For pharmacological treatment, analgesics and anti-inflammatory medications are important in arthritis pain management and should be used concurrently with nutritional, physical, educational, and cognitive behavioral interventions. You need to consider efficacy, adverse side effects, dosing frequency, patient preference, and cost when selecting medication for pain management. several monotherapies with DMARDs for adult rheumatoid arthritis. Research suggests no regimen is clearly superior to others. Combination therapy improves response rates in some patients who were previously taking monotherapy. The importance of early aggressive disease-modifying treatment in improving outcomes has been well established. DMARDs are used in first-line treatment as soon as the disease is diagnosed. To prevent joint destruction and deformity, these DMARDs are useful. Methotrexate and leflunomide are considered first-line choices in patients with more aggressive rheumatic disease, such as synovitis plus extra-articular manifestations. If the disease is mild, non-steroidal anti-inflammatories at full therapeutic doses are recommended for 2 to 3 months. Hydroxychloroquine and sulfasalazine are added if the disease does not remit after trial of non-steroidals. They generally are chosen for the lower incidence of serious adverse effects when compared with the other DMARDs. The use of hydroxychloroquine is used with caution in patients with renal or hepatic function impairment or a history of alcohol abuse. It can cause irreversible retinal damage. Patients should wear sunglasses in bright sunlight because the eyes may become photosensitive. The immunomodulators share common side effects. Serious infections, sepsis, and fatalities have been observed in treated patients, many of whom were receiving other immunosuppressive agents at the same time. Rare cases of TB have also been reported. All candidates for immunomodulator therapy should be assessed for TB risk. Anti-TB therapy should be considered before initiation of a cytokine immunomodulator in those deemed to be at risk. Patients with serious chronic infection and those who require live virus vaccination should not be given a cytokine immunomodulator. The FDA has noted continued reports of rare malignancy, hepatosplenic T-cell lymphoma, occurring in patients who are receiving TNF blockers, and healthcare providers are required to notify the FDA and drug makers if patients aged 30 or younger develop malignancies while on this drug. Biological agents also seem to be associated with increased risk of skin cancer, according to recent published studies. Again, combination therapy generally is used because it's more effective and provides a more sustained response. Immunomodulators are often used with methotrexate, but they're generally not used in combination because of the increased rate of adverse effects. Overall, the response rate is about 50%. This means that half of patients with the rheumatoid arthritis do not have a good response to any of these drugs. Treatment regimens for rheumatoid arthritis are evolving as newer drugs are introduced, and you need to keep your eye out for new developments. How do we monitor these? The rheumatologist or clinician specialist working in rheumatology who follows these patients should monitor the patient closely. Indicators of a reduced disease activity include decreased ESRs and C-reactive protein. ESR is used over time to monitor disease activity. Patients who are taking the DMARD should be monitored closely for adverse effects. The usual parameters that should be monitored include CBC with a differential and platelets for blood dyscarrias, metabolic panels for hepatic and renal function, and a urinalysis. Hydroxychloroquine, you need to do periodic blood cell counts during prolonged therapy and refer the patient to an ophthalmologist for baseline and every 3-month examinations. You need to also assess patients for muscle strength and knee and ankle reflexes. For adverse effects, sulfasalazine, you need to perform a CBC, including differential, white blood count, and LFTs before starting and every second week during the first 3 months of therapy. During the second 3 months, you need to perform the same tests once monthly and thereafter every 3 months and as clinically indicated. You need to also perform urinalysis and an assessment of renal function periodically during treatment. Again, these are patients are commonly followed by a rheumatologist, and they may be ordering these tests or may depend on you. Methotrexate, you need to get a CBC, albumin, creatinine, and LFT at baseline and then monthly for 6 months and every 1 to 2 months thereafter. Baseline alkaline phosphatase, chest radiograph, and hepatitis B and C serology should be done in high-risk patients. Patients with a history of inflammatory bowel disease should not be given golimumab as a treatment for rheumatoid arthritis, ankylosing spondylitis, or psoriatic arthritis can become a problem. The usual parameters that should be monitored for patients who are taking immunomodulators include TB tests before the initiation of therapy, assess the risk factors for infection, monitor signs and symptoms of infections, and monitor CBCs, LFTs. Patient variables. Used with caution in patients with hepatic or renal insufficiency because these drugs may accumulate and cause toxicity. For geriatric patients, they are more susceptible than others to adverse effects. The frail elderly do not usually tolerate this aggressive category of drugs. Use methotrexate with caution and decrease the dose because hepatic and renal functions are diminished in this population. For pediatrics, use extreme caution when administering these drugs to children. These agents have caused death, and again, rheumatologists will be prescribing. Although disease-modifying antirheumatic drugs appear to be more effective for treating juvenile idiopathic arthritis than ibuprofen or corticosteroids, not much evidence concerning long-term use exists. So you need to use caution of these medications. Pregnancy and lactation, again, hydroxychloroquine is category C. In lactation, it's probably safe. However, research is lacking. For sulfasalazine, it's considered category B in pregnancy, and safety is unknown in lactation. For methotrexate, it's considered category X and should never be used, and it is considered unsafe in lactation. The TNF inhibitors are considered category B, but no adequate studies have been performed. And again, lactation, no studies have been performed. For the interleukin-1 inhibitors, these are considered category B. Lactation safety is unknown, and the T-cell modulators, abatacept is considered a category C, and lactation safety is unknown, and the leflunomide is considered category X, should never be used in pregnancy, and it's considered unsafe in lactation. That was kind of a quick review of those medications. Again, these are prescribed by rheumatologists, and you need to monitor the patients and be familiar with the drugs if they're on it. We'll now move on to patients who have gout and medications that are used in the treatment. Mostly these include the non-steroidal anti-inflammatory drugs, indomethacin, naproxen, and Solondac, colchicine, uricosuric agents such as probenecide, and xanthine oxidase inhibitors such as allopurinol. These are indicated for hyperuricemia, prophylaxis of gouty arthritis, and acute gouty arthritis. Mechanism of action. These drugs use 3 mechanisms. They increase the excretion of uric acid, decrease the synthesis of uric acid, and decrease or stop inflammatory responses. The nonsteroidals in anti-inflammatories inhibit the prostaglandin synthesis, thereby reducing the intensity of inflammation and pain in the injured tissue. The exact mechanism of colchicine is unknown. However, it affects leukocyte function to reduce lactic acid production. This results in decreased uric acid and reduction in the inflammatory response. Colchicine has no effect on uric acid metabolism and is not an analgesic. Uricosuric agents such as probenecide are tubular blocking agents. They decrease serum uric acid levels by increasing urinary excretion of uric acid caused by inhibition of tubular reabsorption of urate. During this process, high concentrations of uric acid develop in the proximal renal tubules. This may predispose the patient to the development of urinary stones. For this reason, increased fluid intake is necessary, and alkalization of the urine is desirable when urosuric therapy is initiated. Probenecid also inhibits the tubular secretion of most penicillins and cephalosporins. This increases the effectiveness of antibiotic use. Allopurinol inhibit xanthine oxidase, the enzyme that converts xanthine to uric acid. This reduces uric acid production by altering the breakdown of purines to produce xanthines rather than urates. Xanthines are much more soluble than uric acid and therefore have a much greater renal clearance. Different from urosuric agents, allopurinol is used. For the cardinal points of treatment, gout treatment should be individualized and guided by principles of your pharmacology. The ACR guidelines recommend xanthine oxidase inhibitors, either allopurinol or febuxostat, as first-line therapy to reduce the uric acid levels. Uricosuric agents such as probenecide, fenofibrate, or losartan can be added if the target serum urate level cannot be achieved with the first-line treatment. Treatment should be titrated to achieve serum urate levels less than 6 milligrams per deciliter, but a reduction to 5 milliliters per deciliter may be needed to control signs and symptoms. You need to consider select pharmacogenic screening of patients for HLA-B 5801 allele, which increases the risk of allopurinol hypersensitivity in high-risk populations. This includes the Han Chinese. Acute flares can be managed with anti-inflammatory agents such as nonsteroidal anti-inflammatories or glucocorticosteroids. Prevention of acute attacks. First line includes colchicine. Second line includes probenecid or uricosuric drugs. Allopurinol if it's an overproducer. Febuxostat if unable to tolerate allopurinol. Urate-lowering drugs are used for long-term treatment, and management of gout requires characterization and modification of risk factors associated disorders. This includes diet as well. For asymptomatic hyperuricemia, although the treatment of asymptomatic patient is somewhat controversial, a blood uric acid level greater than 7 may warrant treatment if the patient has multiple other risk factors. However, most clinicians recommend that asymptomatic hyperuricemia not be treated. Non-pharmacological treatment or management of asymptomatic gout is generally attempted. Adequate fluid intake is necessary. Preventative measures include managed weight loss, primary prevention of hypertension, decreased alcohol consumption, and dietary modifications to reduce purine intake. A low purine diet restricts the consumption of meat and prohibits alcohol, liver, kidneys, sweetbreads, dried beans, and peas, mushrooms, lentils, spinach, anchovies, sardines, and whole grain and bran breads and cereals. For acute gouty arthritis, the goal of therapy is to decrease or stop the inflammatory response. Treatment of acute gout usually begins with nonsteroidals. Pharmacological treatment of hyperuricemia must be started after the acute attack has subsided. Initiate treatment immediately and put the patient on bed rest for the first 24 hours. Nonsteroidals are the drugs of choice for reducing the inflammation and pain of acute gout. Nonsteroidal anti-inflammatories indicated for gout include indomethacin, naproxen, and sulindac, but all nonsteroidals are somewhat effective. Indomethacin traditionally has been used most frequently, however, it's associated with high risk of adverse events, and the newer nonsteroidals are considered equally potent. If the patient is at high risk for GI bleeding, the COX-2 inhibitors may be appropriate. Colchicine is used for the acute attack, but is no longer recommended as first-line treatment because of nausea and vomiting that often occur prior to the relief of pain. Corticosteroids are very effective, but should be reserved for patients who are unable to take the nonsteroidals or colchicine. Corticosteroids are given by intra-articular injection if the gout is monoarticular. Opioids are used to treat severe pain if required. A newer interleukin-1 trap drug, rilonacept, has also been used to control pain of an acute gouty attack, but little information is still available. For prevention of reoccurrence, the rationale that underlies therapy is that increasing the excretion of uric acid or decreasing the synthesis of uric acid reduces the frequency and severity of acute attacks. Also minimizes the urates in the tissue. The cause of chronic tophius arthritis. The decision to treat the intercritical period based on the likelihood of additional attacks is how you decide whether the patient will be on long-term therapy. Patients who are able to make significant lifestyle changes may not need medication. Patients at high risk for recurrence, such as patients on diuretics, elderly, or mild renal failure, probably need treatment. Colchicine may be sufficient as prophylaxis in patients with normal renal function because the primary mechanism of pain in an acute gout attack appears to be the inflammation that results when granulocytes phagocytize monosodium urate crystals. Interference in this cycle will prevent an attack. It is also used as adjunct therapy to prevent acute attacks when urosuric and allopurinol therapies are started. Significantly fewer attacks are seen at 6 months in patients receiving colchicine at 0.6 milligrams twice daily versus those who were given a placebo of 1.8 milligrams. If an acute gout attack occurs while the patient is on colchicine, the drug should be continued or increased, and another agent such as a nonsteroidal should be added. Colchicine has a fairly narrow therapeutic window and high risk of adverse effects such as nausea, vomiting, diarrhea, and abdominal pain. For reduction in serum uric level, this is accomplished with urosurics or allopurinol. Urosurics are used to prevent and treat the tophi, and in combination with colchicine help to prevent acute attacks. Probenecid should not be given within the first 2 weeks of an acute gouty attack because it may intensify and prolong the inflammation. An increased frequency of attacks is fairly common during the first 6 to 12 months of probenecid side therapy. Allopurinol lowers uric acid levels in both under-excretors and overproducers. It is especially useful in overproducers unresponsive patients and those with uric acid renal stones. Decreases in uric acid in both serum and urine are usually evident within 2 to 3 days after initiation of therapy. Allopurinol should not be started during the acute phase of gout because the drug has no anti-inflammatory or analgesic action, and it may prolong the acute phase of gout. It should not be used for the treatment of asymptomatic hyperuricemia. As with probenecid, allopurinol has a tendency to increase the frequency of attacks during the first few months of therapy, so concurrent administration of colchicine is recommended. Allopurinol is very effective in shrinking and eliminating the tophi. A serum level of uric acid below 5 milligrams per deciliter may be necessary in these patients. This can be accomplished through the addition of uricosuric. Colchicine will not prevent the progression of the tophi gouty arthritis. How do we monitor these patients? You need to perform baseline serum uric acid levels, then monitor every 2 to 3 months. Normal serum acid levels in men range from 2 to 7 milligrams per deciliter. In women, between 2 to 6. For a gout patient, ideal serum urate concentration is 5 to 6 milligrams per deciliter. For the nonsteroidals, obtain a baseline kidney and liver function test, especially in the elderly. Short-term use is recommended with these drugs, and monitor for adverse reactions. GI disturbances occur up to 60% of patients taking nonsteroidals long-term. The incidence of GI side effects increases with age. For colchicine, first-time administration, patients should be monitored weekly for signs of toxicity. This includes weakness, nausea, vomiting, diarrhea, and anorexia. Periodic liver function tests and blood counts every 3 to 6 months should be performed if the patient is on long-term therapy. Colchicine can cause reversible malabsorption of vitamin B12, so periodic monitoring of B12 levels may alert you to a potential deficiency. Xanthine oxidase inhibitors, you need to obtain a baseline CBC and serum levels and repeat every 2 to 3 months for those receiving allopurinol. Serum uric acid is the best test to use to evaluate the efficacy of therapy. Renal function testing, especially BUN, creatinine, and creatinine clearance, should be monitored in patients with renal disease or any other disease that can affect renal function. Allopurinol hypersensitivity syndrome occasionally may develop and be life-threatening in patients. It's apparently a dose-dependent hypersensitivity that presents with fever, eosinophilia, dermatitis, hepatic dysfunction, renal failure, and vasculitis, and is associated with mortality rate of approximately 20%. The syndrome may be prevented by starting with a low dose below the creatinine clearance-based dose before raising it slowly to a therapeutic level when tolerance is achieved. For patient variables, geriatric patients, elderly patients frequently have diminished renal function, and the risk of adverse renal effects is increased. You need to begin at the lowest recommended dosage and monitor renal function. Colchicine adverse reactions have resulted in death. Gastrointestinal toxicity occurs in up to 80% of the patients. Bone marrow suppression, blood dysureas, hepatic necrosis, and seizures are more common in the elderly. For pediatric patients, safety and efficacy is not established for colchicine. Sulfentrazone, febuxostat, probenecid is contraindicated in children younger than 2 years of age. It's used with penicillins and cephalosporins to prolong duration of action. Allopurinol should not be used in children with hyperuricemia related to malignancy or in those with certain rare inborn errors of purine metabolism. For pregnancy, it's considered Category B, probenecid, Category C, colchicine, allopurinol, and febuxostat, and Category C/D for sulfentrazone. Patient education, all gout therapies. Lack of patient education is probably the most important barrier to optimal management of gout. Education about the disease, triggering factors, lifestyle changes, and rationale of using various drugs may help to improve the patient's adherence with treatment and treatment outcomes. The patient needs to maintain adequate fluid intake, take medications with the food to prevent GI upset, report any symptoms of GI distress, and lose weight slowly on an improved weight loss diet. Quick weight loss may bring on a gouty attack. Stress the importance of medication compliance despite the absence of attacks. For the non-steroidals, the patient should notify healthcare providers if increased swelling or pain develops. The non-steroidals can mask symptoms of infection, and dizziness may occur when some of the non-steroidals are initiated. Engaging in tasks that require mental alertness may be hazardous, so the patient needs to watch for signs and symptoms. Also, for signs and symptoms of GI bleeds, such as lethargy, fatigue associated with anemia, that accompanies the slow, persistent, small bleeds that often unaccompanied by the usual signs and symptoms of more substantial bleeds. Colchicine, the patient needs to be notified, the patient healthcare provider, if a skin rash, sore throat, fever, unusual bleeding, bruising, tiredness, weakness, or numbness, as well as tingling occurs. For those on urosuric agents, they need to avoid taking aspirin or other salicylates because of these may cancel the efficacy of each drug. They need to increase the fluid intake to prevent uric acid kidney stones. They should drink at least 6 to 8 ounces of water per day. Drinking 10 to 12 glasses of water usually keeps the urine diluted. They also need to notify practitioners if rash develops. Allopurinol, the patient, it's been shown that almost half the patients who are taking this drug do not take the dosage as prescribed. Patient education is essential. They need to notify the provider of skin rash, painful urination, blood in the urine, irritation of the eyes, or swelling of the lips and mouth occurs. Large doses of vitamin C may increase the possibility of kidney stone formation. You need to advise the patient that acute attacks of gout may occur during the early stages of this therapy, and allopurinol usually is best tolerated if taken with food or milk. Fluid intake sufficient to produce urine output of at least 2 liters per day is necessary to prevent the formation of kidney stones. It may take up to 6 weeks for optimal benefit to be attained with the drug. Until then, the patient must continue to take any other anti-gout medication used previously. Now we're going to move on to muscle relaxants. Muscle relaxant drugs are chemically unrelated. In general, they are divided into 2 types, the antispasmodic drugs and the antispasticity agents. Some drugs have properties of both types. The first group consists of centrally acting sedatives and the tricyclic antidepressants. Relative cyclobenzaprine. Naloxone is treated as the key drug for centrally acting sedatives because it's most commonly used. Cyclobenzaprine is also used frequently. The benzodiazepines and the centrally acting alpha-2 adrenergic agonists tizanidine have antispasmodic and antispasticity actions. The GABA receptor stimulant baclofen is used only for spasticity. An older drug, Soma, is still on the market but has decreased in use because when misused or taken with other prescription medications, recreational drugs or alcohol can have a dangerous sedative effect on these patients. The sedative effect of narcotic painkillers or anti-anxiety medications may also be potentially potentiated by Soma. So for indications, the CNS sedatives are used for musculoskeletal conditions as an adjunct to rest, PT, and comfort measures. The cyclobenzaprines are used for musculoskeletal pain and muscle spasm. Tizanidine is used for spasticity. Benzodiazepine is used for muscle spasms, specifically diazepam, and baclofen is used for spasticity resulting from MS and spinal cord traumas. The centrally acting sedatives are CNS depressants. The exact mechanism of action is unknown. These agents do not work directly on skeletal muscle, nor do they work at the neuromuscular junction. They achieve their effect on localized muscle spasms by producing sedation in the patient. This sedation causes a decrease in facilitative and inhibitory neural activity, which affects the muscle stretch reflex. These agents do not have analgesic or anti-inflammatory properties. They have been found to reduce the involuntary contractions and muscle spasms that result from skeletal muscle injury and are effective against peripherally caused muscle spasms. Centrally active sedatives are inactive in treating spasticity of muscles caused by CNS diseases. Methylcarbamol causes CNS depression. It has no direct action on the contractile mechanism of striated muscles or on nerve fibers. Chlorzoxone acts at the spinal cord and subcortical levels, inhibiting multisynaptic reflex arcs. Carisoprodol, which blocks intraneural activity in the descending reticular formation and spinal cord, is metabolized to meprobamate, which is similar to barbiturates. Therefore, these medications are not recommended, especially to be prescribed by the primary care provider. These medications may be prescribed by pain management or neurologists, and you may see them in passing, but those will be managed by those specialists. For the tricyclic the TCAs, cyclobenzaprine or Flexeril, very commonly used, is structurally related to TCAs. It acts in the central nervous system to reduce tonic somatic motor activity. It causes risperidone antagonism, norepinephrine potentiation, substantial anticholinergic effects, and sedation. It is also effective in the treatment of non-CNS muscle spasms such as TMJ pain. Flexeril works at the brainstem. Orphenadrine is similar to Flexeril but is not as commonly used. Flexeril provides an added benefit of aiding sleep, which often presents a problem for patients with back pain. The benzodiazepine, specifically diazepam, which is Valium, is the only benzodiazepine with the indication for muscle spasm. It has direct skeletal muscle relaxant action in the brainstem and at the spinal cord level, enhancing the GABA-mediated presynaptic inhibition. Diazepam may be used for both skeletal muscle strain and spasticity caused by upper motor neuron disorders. Also commonly used with seizures. The GABA receptor stimulants, such as baclofen, is effective only for muscle spasm caused by CNS diseases. It inhibits monosynaptic and polysynaptic reflexes at the spinal level and is a structural analog of aminobutyric acid, the inhibitory neurotransmitter. The alpha-2 adrenergic receptor agonists, such as tizanidine, is an imidazoline derivative and alpha-2 adrenergic receptor agonist that is related to clonidine and has a centrally mediated myospasmolytic action. It has muscle relaxant, anti-neo-septive and gastroprotective properties, which lowers gastric acid secretion. Tizanidine is effective for both CNS and non-CNS spasms. So what are the treatment principles? Evidence-based recommendations. Medications with good evidence of short-term effectiveness for low back pain include the nonsteroidals, acetaminophen, skeletal muscle relaxants for acute low back pain, and TCAs for chronic low back pain. Evidence is insufficient to identify one medication as offering a clear overall net advantage because of complex trade-offs between benefits and harms. Individual patients are likely to differ in how they weigh potential benefits, harms, and costs of various medications. For the cardinal points of treatment, analgesics, the first line therapy is nonsteroidals and acetaminophen. Second line includes muscle relaxants, tramadol, opioids if severe debilitating pain, and muscle relaxants are first line is flexural or centrally acting sedatives. Patients often seek over-the-counter medications and complementary and alternative medications for their back pain before visiting the primary care. They frequently do not tell their healthcare provider about their use or other treatments unless questioned, and they frequently continue to use them regardless of the therapeutic regimen that you provide. So it's very important to investigate this. For non-pharmacological treatment of acute injury consists of rest and ice. Ice is used for the first 24 to 48 hours. Heat or ice alternating with heat then may be applied. Physical therapy may be indicated as the injury begins to heal. Chronic muscle spasms also should be treated with physical therapy. Special pillows may be used along with bed rest, office chairs, or car seats to help take pressure off the low back area and help the body with good alignment. Pharmacological treatment, medications for acute muscle injury begins with nonsteroidals and acetaminophen. If used alone, are ineffective in relieving pain, or if muscle spasm is a significant component of the patient's complaint, a muscle relaxant may be considered. Skeletal muscle relaxant should not be used for longer than a week because muscle spasms seldom last longer than that. When prescribed for acute muscle spasm, these drugs are used as adjunctive therapy. For drug selection, because of the similarities among the drugs, you should become familiar with one or two of the sedative muscle relaxants. Methaxalone and methylcarbamol are the most commonly used. Flexeril, which has a different mechanism of action, is the most frequently used muscle relaxant. Diazepam is the only benzo used for muscle relaxation and indicated for muscle relaxation, and is the only drug in this category with direct muscle relaxant effects. It's very effective for short-term relief of severe muscle spasms. However, because of its abuse potential, it should be used only on a short-term basis, and the amount of medication should be monitored closely. Other benzodiazepines have indirect effects as muscle relaxants. They offer the advantage of a shorter half-life and with fewer adverse reactions. Lorazepam is often used, and baclofen is used for CNS disorders with severe muscle spasms. How to monitor these patients: you need to watch for reduction in severity and duration of muscle spasms, monitor for sedation or dizziness, perform liver function tests in patients at risk, and all of these drugs have some risk of abuse and addiction. Carefully evaluate the patient's use of the drug and the response to it. Consider giving a limited amount of drug to patients who seem to have high risk for abuse. For patients' variables, geriatric patients, elderly patients may be more susceptible to the sedative effect of muscle relaxants. So these medications must be used very cautiously in this population. Use of these agents puts elderly at risk for increased falls, so you need to be aware of this. And patients who engage in driving for long distances may particularly be at risk and should use special pillows to support their lower back area. For pediatric patients, safety and use in children younger than 12 has not been established. For those pregnant and lactating women, again, safety for use in pregnant women has not been established. In lactation, it's not known whether these medications are excreted in breast milk. For patient education, Again, remind the patient that it may cause sedation and may decrease mental alertness. Patients should use caution when performing hazardous tasks. They should not drink alcohol or take any other CNS depressants with the skeletal muscle relaxants because of the effects are additive. They need to notify the provider if a skin rash or jaundice occurs because these may be linked to more significant adverse effects. For the centrally acting sedatives, CNS depressions such as scalaxin, contraindications, again, you should be looking these up, as well as hypersensitivities. If the patient is hypersensitive to this drug, then it should never be used. For warnings, this does cause hepatic function impairment. It should be administered with care to patients with pre-existing liver damage, and you should perform serial liver function studies as needed. Discontinue the drug if signs or symptoms of liver dysfunctions observed. It also may impair mental or physical abilities. The patient should be told to use caution when driving or performing tasks that require alertness, coordination, or physical dexterity. It should not be given to those with a history of drug-induced hemolytic anemia or other anemias. For adverse effects, CNS, it causes drowsiness, dizziness, headache, nervousness, and irritability. For GI, nausea, vomiting, and GI upset has been seen. And hypersensitivity, such as a light rash with or without pruritus, leukopenia, hemolytic anemia, and jaundice have been observed. For drug interactions, may enhance the effects of alcohol, barbiturates, or other CNS depressants, and may produce false positive Benedict's test results when blood sugars are tested. Again, dosage administration should be looked up when prescribing this drug. For other centrally acting agents, Flexeril should be contraindicated with hypersensitivity or during acute recovery phase of an MI, patients with arrhythmias, heart block, or conduction disturbances, or CHF. Should not be used with patients with hyperthyroidism or used with patients who are on MAOIs within the past 14 days, as may cause a hyperparetic crisis, seizures, or death. For warnings, the experience with long-term use is limited. It can cause orthostatic hypotension, so cautious with the elderly, hepatocellular injury, sedation in 50% of the patients, and hallucinations or delusions. Precautions, you use cautiously with patients with prolonged QT intervals or bradycardia. Can cause retinal degeneration and corneal opacities in animals. Renal disease, clearance is reduced by more than 50%, and monitor ophthalmic and liver function at baseline and at 1, 3, and 6 months, and then periodically. For adverse effects, serious adverse effects include hepatotoxicity and bradycardia. For common adverse effects include orthostatic hypotension, dizziness, dry mouth, somnolence, and weakness. Asthenia, urinary urgency, blurred vision, flu syndromes, dyskinesia, nervousness, pharyngitis, rhinitis, increased spasticity, and tone has observed in some patients. For drug interactions, these drugs interact with oral contraceptives. Use caution and reduce the dose. Tizanidine delays the action of acetaminophen. Alcohol increases the blood level of tizanidine. These are potent CYP1A2 inhibitors. These will react with potent CYP1A2 inhibitors. They may increase the effects of tizanidine. Significant orthostatic hypotension may be seen. Drugs such as ketoconazole, norfloxacin, ofloxacin, and rofecoxib are contraindicated with these agents. Ciprofloxacin may increase the levels and cause hypotension when prescribed with tizanidine. Concurrent use is contraindicated. Diuretics and other alpha-adrenergic agonists and antihypertensives may induce additive hypotensive effects. Fluvoxamine may increase levels and cause hypotension of tazanidine. Again, concurrent use is contraindicated. And mirtazapine may antagonize the alpha agonist effects of tazanidine. So you need to be cautious and look for possible drug interactions when using these medications on your patients.